Adjunctive false lumen intervention for aortic dissection is safe but offers unclear benefit. Will be presented by Ray Rokush on behalf of authors representing NYU, Boston Medical Center, and Columbia University.
My name is Ray Rokush, and I'm a general surgery resident from NYU. I'd like to thank the Society for giving us the opportunity to present our work entitled Adjunctive False Lumen Intervention for Aortic Dissections is Safe but Offers Unclear Benefit. The authors have no relevant disclosures to declare. TEVAR has been proven to have a high rate of technical success, minimal associated morbidity or mortality, and beneficial short-term positive aortic remodeling when used to treat both acute and chronic type B aortic dissections. Covering entry tears using TEVAR leads to depressurization of the false lumen and results in variable degrees of thrombosis. Complete false lumen thrombosis is associated with positive aortic remodeling and favorable midterm outcomes. However, TEVAR alone is insufficient to achieve adequate false lumen thrombosis in up to 50% of patients. Patients often require secondary aortic interventions, especially for chronic dissections, due to persistent false lumen pressurization secondary to distal reentry tears or incomplete endograft expansion within a stiffened, less compliant dissection flap. Incomplete thrombosis of the false lumen is a known poor prognostic marker and associated with aneurysmal degeneration. Thus, given the aforementioned limitation of TEVAR alone, false lumen embolization, or FLE, offers a potential adjunct to induce false lumen thrombosis. There have been several small single institution experiences that have demonstrated mixed results with FLE as an adjunct to TEVAR, and in this study, we examined perioperative and midterm follow-up outcomes of patients that are undergoing concomitant TEVAR and FLE for chronic aortic dissections to evaluate the utility of adjunctive embolization and management. Patients 18 or older who underwent TEVAR for chronic aortic dissections with known FLE status in the SVS-VQI database between January 2010 and February 2020 were included. Patient characteristics, operative details, and outcomes were analyzed by group, so TEVAR with or without FLE. Primary outcomes of interest were in-hospital postoperative complications and all-cause mortality, and secondary outcomes included follow-up mean maximum aortic diameter change, rates of false lumen thrombosis, reintervention rates, and mortality. Notably, we excluded patients with pathology other than dissection, those presenting with acute dissections or ruptured, patients undergoing emergent procedures, or those without a documented FLE status, as well as patients with a proximal extent of dissection distal to zone 6. There was no significant difference between the groups in terms of age, sex, tobacco use, preoperative statin use, or cardiovascular comorbidities, including hypertension, diabetes, and coronary artery disease. There was also no difference with respect to connective tissue disorders or history of prior aortic intervention between the two groups. Notably, patients in the TEVAR FLE group were significantly more likely to have a more proximal extent of dissection. However, there was no significant difference in mean maximum preoperative aortic diameter or symptomatic presentation between the two groups. Indication for intervention was similarly distributed between TEVAR FLE versus TEVAR alone, with persistent pain and associated aneurysm being the most common indications for intervention. Of those who underwent TEVAR FLE, 48% had coils, 46% had plugs, and 6% had a combination thereof. FLE was associated with significantly longer procedural times, increased contrast use, and prolonged fluoroscopy. However, there was no significant difference in estimated blood loss or transfusion requirements between groups. With the exception of access-related complications, patients undergoing TEVAR FLE did not have any significant increase in the incidence of perioperative complications, including spinal cord ischemia, as you can see here. The groups also had similar index admission aortic-related reintervention rates, post-procedural intensive care length of stay, and total postoperative length of stay. In-hospital all-cause mortality was also not significantly different between the groups, as you can see here. There was a non-significant trend towards lower all-cause mortality in the TEVAR FLE cohort, 2.2% versus 7.8% in the TEVAR alone group, at midterm follow-up, which was a median of 15.5 months. However, Kaplan-Meier survival analysis demonstrated no long-term difference in overall all-cause survival between groups, with a p-value of 0.23. After adjustment for potential confounders, postoperative complications had the strongest independent association with overall mortality, increasing the hazard of death over twofold. Overall, the duration of follow-up was similar between the two groups. There was similarly no difference in reintervention rates during follow-up, and while there was no aorta-specific deaths in the TVAR FLE group, the TVAR alone cohort was associated with 1% overall aorta-specific mortality. A total of 337 discharged patients had complete pre- and post-operative imaging available for comparison. And in this group, we found that there was no significant difference in mean maximum aortic diameter change. A smaller subset within those 337 discharged patients with available follow-up imaging had documented false lumen status. In this cohort, there was no significant differences between groups in terms of false lumen status in the TVAR-treated aortic segments. However, the proportion of complete false lumen thrombosis was higher in the embolization cohort compared to TVAR alone. In conclusion, adjunctive FLE is safe and can be performed for patients with chronic dissection without significantly higher overall perioperative morbidity or mortality. There were trends for improved survival and increased rates of false lumen thrombosis in the treated thoracic segment. However, given the lack of evidence to suggest a significant reduction in reintervention rates or induction of more favorable aortic remodeling compared to TVAR alone, the overall utility of this technique in practice remains unclear. Further investigation is needed to determine the clinical circumstances and patient populations that are most suitable for implementation for FLE in the management of chronic aortic dissections. This study, as a retrospective study, had a few limitations. As a retrospective review of prospectively collected data, the granularity of information that was available for analysis is limited. For example, the rationale for performing FLE is not provided, and the specific technical details of FLE intervention are lacking. Furthermore, despite overall similarities in baseline characteristics, the FLE cohort may inherently be more complicated given more frequent extension of dissection into the ascending and aortic arch, though this patient complexity is similar to that's seen in the pre-existing literature. In addition, there is some evidence that the clinical benefits of improved survival and aortic remodeling may not become apparent until 2 to 5 years after the index procedure. However, the follow-up for our entire cohort was limited to a median of just under 1.5 years. And so while this study failed to identify significant midterm benefits with TVAR FLE, it does not preclude the possible late-term benefits of this adjunctive intervention. Lastly, of patients that had follow-up, only 38% had further imaging for evaluation, which could have impacted our results as well. That is all that I have. Thank you so much for your attention, and I would be happy to answer any questions.
Thank you very much, Dr. Rokush, and congratulations on your presentation. I have a couple questions. We'll go to the on-screen ones first. Ravi Rajani says, great presentation on a very interesting topic. Given the very small size of your false lumen embolization group, did you consider propensity matching to minimize the selection bias?
Yes, this is something that we considered. Unfortunately, the number of people even who had false lumen status available in follow-up was 7. And so we could propensity score match, but I don't know how high yield that would be for that low of a patient cohort.
Yes, thank you. Greg McGee asks, with less than half the patients in the FLE group having data on false lumen thrombosis, how do you determine if there is a benefit or not?
Yeah, so unfortunately, just given the lack of granularity that you have with the VQI database, particularly the follow-up, our study wasn't necessarily powered, given the deficiency in the follow-up, in order to make any definitive conclusions about the utility of false lumen intervention at this point, which is why we say that we think that it warrants further study.
Jordan Stern says, how do you account for differences in patient-specific anatomy? For example, patients undergoing a candy plug adjunct would not be the same anatomically as those who are suitable for other techniques, such as a cheese wire balloon septal rupture or Knickerbocker technique.
Yeah. So again, due to the granularity of the VQI database, we don't know the rationale for performing the FLE. We also don't know the specific technical details of the FLE intervention. Those are lacking. In addition, there are coils plugs, and there's also reports in the literature of using glue or the candy plug technique. But even, in the pre-existing literature, those outcomes are variable and often derived from very small case series as well.
Jason Lee recommends the following. He says that this study would be well served by the society given the institutions and our membership. We would be able to provide more granular data and better follow-up than the VQI if we did this as a multi-center trial together from the VESS. I think it's a great idea for collaborative across the society, and I guess we'll punt this to the executive committee and perhaps our research council to take on.
Yeah, thank you. I appreciate that. That would be an excellent opportunity to pursue.
Ravi Rajani says, thank you for your thoughtful answer. Very nice presentation and follow up to his earlier question.
Thank you.
I had a question for you. You said that this cohort is chronic dissection patients. You have excluded those who were acute, yet 40% or more of your patients were symptomatic as an indication for treatment. How were they symptomatic when they are several months out from their initial dissection, and what were the symptoms that triggered repair?
Yeah, so our groups were matched in symptom presentation. Everyone who was ruptured was excluded. Symptoms we considered to be like an acute on chronic in this chronic population. So everyone based in the VQI who was listed as chronic had a dissection that had been present for 30 days or more, just based on the definition that the VQI uses. And then symptom for that would just be pain. Was the predominant one that's captured in the VQI.
And then in addition, you said that 40% of your patients had a prior aortic intervention. Do you know if those were interventions specific for their dissection or not, and how that might have impacted your results?
Yeah, so the prior interventions were independent from the dissection. And it's while the FLE group notably had a larger history of prior interventions. This is pretty well matched in the literature. There are several other single institution studies, and on reviewing those, commonly prior aortic interventions range from anywhere between 20 and 50% in those cohorts as well.
Wonderful. That's all the time for questions we have. So thank you very much for, again, your presentation and for answering our questions.
Thank you so much.